The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everybody, and welcome back to the Flightbridge Ed MDcast. My name is Mike Loria. I am an emergency medicine, EMS, and critical care physician and the medical director for Flightbridge Ed. And today I'd like to introduce part 2 of our series on OB critical care. We'll be talking about maternal cardiac arrest and CPR. So as we started out, just to introduce this series with our first episode, I'll reiterate that maternal death has been a problem, a big problem in the United States. That's been getting worse since the 1980s. Currently, our rates of maternal mortality are about 32, almost 33 deaths per 100,000 compared to other countries around the world like Norway or Iceland that are reporting about 1 or 2. We've slipped to about 65th in terms of our OB mortality rate, which is really bad and likely reflects issues with access to care and some of our marginalized populations that are not getting really good or not able to get really good OB critical care and or OB care services in general. And our job from a critical care transport perspective is to be able to help and provide transport services to moms that are critically ill. And I think that that's important because actually a lot of the places that deliver some of these patients and interact with pregnant females are not tertiary or quaternary care centers. So they can have very sick mothers that walk in the door, and we'll have to help get them to the care that they need. In order to help me with this series, I'd like to introduce once again Dr. Elizabeth Garchar. She is an OBGYN and maternal fetal medicine specialist. She did medical school here at the University of New Mexico, as well as residency and fellowship. And again, very uniquely, she has been very involved with our flight program. She's probably one of the only OBs, MFMs that I know who has flown with us on many missions out to some of these small outside facilities. And we are keeping around as one of our assistant medical directors for the program. So welcome yet again, Dr. Garchar.
Thanks so much. So excited to be here.
To start out, again, we have no conflicts of interest or disclosure, so if we talk about any particular products or devices, it's because we think that they're useful or in clinical practice or because there's good evidence to support their use. Also, in this podcast, we're going to talk about evidence-based medicine, resuscitation, and critical care for some of these patients, but just remember that none of the stuff we talk about in this podcast should ever supersede your local protocols, guidelines, regulations, or laws. So today, we're going to talk about a really sad and unfortunate topic that's really scary for just about everybody, maternal cardiac arrest and CPR. So again, really scary and sad if it gets to this point, but and it actually can be very overwhelming, right? It's very rare that we run into this otherwise healthy population that's in cardiac arrest. Sadly, I would say in New Mexico, we see quite a few because of drug issues and other complications due to low access to care, but we can potentially intervene to help these mothers out. And cardiac arrest is rare, but it's unfortunately, again, kind of like all the other complications, increasing. It used to only occur in about 1 in about 20,000 pregnancies, and now in the United States, sadly, it's closer to about 1 in 12,000. So it is overall, again, very rare, but becoming more common. There's a substantial number are trauma, especially things like intimate partner violence. That's up to about 20% of these arrests. Drug overdose, reported in 2012 as 8%, but has likely been on the rise, especially with the epidemic of fentanyl and other drugs that we're seeing on the street. There are more rare things that cause it, like amniotic fluid embolism, which we'll do a whole podcast on later on. That's about 13%. Preeclampsia, about 18%, and sometimes underlying cardiac complications, often that haven't been previously diagnosed, can contribute up to about 20% of these. But it's often survivable. So this is the really good news that in general across the adult population, don't necessarily quote me on this, but the last time I looked at the literature was somewhere in the teens, like 12% to 70% all-comer, good neurologic survival in cardiac arrest in adults, all-comers, right? In this case, if you look at this population in particular, that if we do things really well and we intervene quickly, there have been documented reports, so in the literature, of about up to 58% neurologically intact survival. And that's largely due to these patients that are otherwise pretty healthy at baseline. They're not our 60 or 70-year-old patients that have cardiac arrests with, bad kidneys and chronic diseases and other organ systems. So their protoplasm, their underlying organ health in general is pretty good. Again, why I think it makes it so important that we really understand and act quickly in the setting of maternal cardiac arrest. So I'll start out with addressing the elephant in the room, which is, I think that people are always really concerned. It's a different population, like kids or pregnant women. They go into cardiac arrest, super scary and very rare for us to experience. But what do we do differently for this population that we would not do for the average adult? So how might our practice change? So Liz, if you had the unfortunate circumstance of having a mom in cardiac arrest, what are some of the things you think about that might be a little bit different in an outside hospital on their labor and delivery floor, on our labor and delivery floor, or in an outside ED that you might do slightly different or think about slightly differently than in the average adult patient that experiences cardiac arrest?
Yeah, so definitely you always have a large team, I feel like, at cardiac arrest, hopefully in the hospital setting, right? But this should be an even larger get help ASAP team. You definitely want to include your obstetricians or someone who's able to deliver the baby, as well as the peds and NICU team, so that they're present in case of delivery, especially if this is a resuscitatable age. We'll talk a little bit more about when to deliver baby, but it can be prior to viability as well, but definitely want them around. And if at a small outside hospital and that's not super an option, I would say get as many people as possible, especially those with some appropriate training. So even if that's the EM physician, any APPs, extra nurses, calling anyone who can help that has especially training in this, and assign them roles and prep them in how to help you. And then another is to, do high quality CPR like you would for any adult, like we said, but then differently, you would want to do a couple of maneuvers. So you want to displace the uterus manually to the left. We used to say to tilt moms, but we find that then you don't do very good CPR. So it's not effective if you're going to make it not work. So actually have a person that is totally dedicated to displacing the uterus manually to the left. Why to the left? We want it on the aorta and not on your IVC, so you have as much flow as possible going that way that you can. We also want to take those monitors that you probably have on the mom off and put them in the trash, essentially. We don't use those during a code. Baby's going to look like absolute crap. We know we're not going to do anything differently in that setting. So don't pay attention to them. So that's another important maneuver. And then something that's unique to this population is their airway. The airway of a pregnant woman in general is just so dynamic, first of all, and definitely so swollen. Women retain a couple extra liters of fluid during pregnancy, so everything is swollen. They can't see as well. Their eyes change. So does their actual airway. And this can be also dynamic in the setting of labor. So when we have our OB anesthesiologists, they intubate very rapidly. They always do it as efficiently as you can, because instead of having that pre-oxygenated state where you got time to kind of futz around, figure it out, you don't have that. People take quickly. So I would say consider intubation early as airway structures are swollen, and definitely keep the management of the airway at the forefront, even though that's changing in the general population.
Yeah, absolutely. And I would say there is some data in the anesthesia literature and the OB literature that suggests that a not insignificant amount, almost like in children, of some of these arrests are due to hypoxia or issues with hypoxia or hypercarbia secondary to ventilatory or breathing problems. It's also, I know that in a lot of the pre-hospital literature, in a lot of the emergency medicine literature, many of you out there are very familiar with many of the studies that show that that supraglottic airways are perhaps just as good as intubation, if not have better rates of survival in the field, or at least ROSC in the field, and that's fair. I would encourage people, even in the absence of some of the really good trials that we have in pre-hospital cardiac arrest, because they are very common in some big metro areas, right? We're talking about 3 or 4 a day. This is a population that does not have, thank goodness, that many cardiac arrests. And so the data may not be as strong, but I would defer to some of our anesthesia colleagues and some of our colleagues that do manage these patients and manage their airways regularly in the hospital. And I respect some of the data that they've collected and their professional opinion in this instance. Specifically regarding the airways things, I think it's not unreasonable if you're used to starting out with a supraglottic airway, maybe just to get going, fine. But I would consider that intubating them perhaps earlier. And we'll go into some of the details about managing that later, or at what time course to do it and why. But the dynamic changes in airway and soft tissue swelling specifically are pretty remarkable, and they are pretty well documented in the anesthesia literature. So I'm glad Liz brought that up, or Dr. Garchar brought that up. Now let's just take a step back practically. And Dr. Garchar, if you are called to, or you land with our team for a sick female, let's say is preeclamptic or develops and is diagnosed with eclampsia and then has a cardiac arrest, going through in your mind, what are some of the step-by-step, the things that you're going to do if this presents right in front of you as you're showing up?
The best mnemonic for this, and what I really try to think about, although I generally need mnemonics for my mnemonics, but I find that some of them really stick with me, and this, I agree, is one of them, was the child mnemonic. So first of all, a C, so call for help. So calling for help and announcing the code, which is sort of the baseline of all of it, getting all of those people there. On labor and delivery, we'd already have ourselves, but we're calling it for the MICU charge at that point to try to help us manage the side we're not used to, that's for sure. And then H of child is high quality CPR like you would for any other adult. So immediately starting, the BLS with displacement of the uterus. So all of those things, but adding in your displacement of the uterus, which we'll get to in the mnemonic. I promise it's in there. And then I is get IV access or more IV access. So in the setting of a person who has a really high risk condition, we generally have 2 IVs anyway, but making sure we have ways to get more or to get good access, making sure that it's especially optimized in this setting. And then L is that promised left uterine displacement. And so that should be done immediately. That can really help with rates of ROSC and also with overall ability to do effective CPR. So super, super important. And then the other things that I'm kind of skipping over in there with the highly effective, high quality CPR are putting on your pads to prepare for defibrillation and being ready with the ability to do that. About 50% of the time you actually have PEA, 25% asystole, but nonetheless, when you can shock, that would be great to have in place and something that you should know if you're able to do it. And then the ALS interventions, of course, which we're going to talk more specifically about, such as medications and airway, and then having your code leader or recorder pay attention to time. Why is that? Because of the D in child, and that's the delivery decision, ASAP. So unlike regular codes, delivery is a part of the equation. So we really want to know how long it's been, because I, as the OBGYN, am going to be wanting to have started my incision at 4 minutes of CPR and finish the, as we call it now, the resuscitative hysterotomy within 5 minutes. So having that as something that you're really thinking heavily about as well.
Absolutely agree. And I think that I'll add 2 things to what Dr. Garchar was saying, which is in the C, call for help, A lot of these mnemonics were developed in tertiary and quaternary centers where there is anesthesia providers and MICU providers and all that other stuff. But as we know, we often land in small, rural, critical access hospitals without any of these subspecialties or people to necessarily help us out. And that's okay, because often there will be still multiple people in the ED, physician, an APP, either a nurse practitioner or PA, that is, and other people that can help. And you really want to get them on board, everybody over there, as soon as possible. Generally speaking, they will come anyway, but you definitely want more hands. And in terms of the delivery decision, sometimes in these situations, a lot of, first of all, I'll start out by saying that it is within the scope of practice for emergency physicians to perform resuscitative hysterotomy in this case. I will tell you that the practice and exposure of the average emergency physician to performing this procedure is exceptionally rare. We don't get a lot of it in residency or fellowship training. So the outside hospital or the sending facility providers may not necessarily be comfortable with this, and a lot of the times we don't even think about it because it's not part of our routine ACLS training. It may be reasonable for you as flight crew members to actually bring this up. Do you think it's appropriate to try and deliver the baby? The person may not be credentialed for it. They may not actually be comfortable with the procedure. But remember, this is pretty time sensitive. So as far as like doing it quickly, especially in the setting when they may be super overloaded from a cognitive standpoint and thinking about all this stuff and really stressed out and scared themselves, bringing it up is definitely reasonable and appropriate. Okay, so the other thing that I'd like to bring up, which I've learned, is that coming up with the differential, and a lot of the survivability is based on fixing underlying problems as quickly as possible. Our colleagues in OB anesthesia have done actually an amazing job at sort of modifying the traditional H's and T's to make essentially like a checklist of reversible causes of maternal cardiac arrest that they've referred to as the A to H guidelines, that provide a quick sort of review of some of the main things that are specific for OB. For example, A is anesthetic complications. So high neuroaxial blocks or administration of medications like magnesium, systemic toxicity that cause the patient to become to hypoventilate and then go into cardiac arrest. Bleeding, so issues with coagulopathy or issues like postpartum hemorrhage that we've talked about on our first episode. Cardiovascular causes, drugs. E is for embolic phenomenon. PE is an amniotic fluid emboli. F is for fever, infection, sepsis. G is for general non-obstetric causes. That's where our anesthesia friends slid in all of the H's and T's that we would normally think about. And last H is hypertensive, so preeclampsia, eclampsia, or HELP syndrome. So this is a nice little checklist that I think is reasonable to have easily accessible, so that when this hits you all of a sudden, you can go through the most appropriate and most common causes specifically for OB cardiac arrest. I think it's always important because we do run into cases, and actually that's why I really love this little checklist. And it starts out with A, which I love, is on the list of things that if you go on to a smaller outside or sending facility that's had a patient on the floor, specifically looking for things to stop. So anesthetic things, so like those epidurals, neuraxial anesthesia, any patient-controlled analgesia. This has definitely been reported in the literature where patients are left with the PCA for their comfort, but due to issues with the mechanism itself or monitoring that has not been optimal, they administer themselves too much medication essentially and stop breathing. And magnesium, although it's generally pretty safe, there have been 66 reported deaths since 1998 that patients have actually become mag toxic. It's gone unrecognized. So all these things that might actually be infusing on the floor of a sending facility, I immediately look at those things and I ask myself, do I need to stop that, stop that, stop that? In fact, I immediately think about those things if I show up at a sending facility and that mother looks really, really sick or obtunded or having issues with respiratory distress or abnormal respiration. So just a thing logistically to think about from a transport environment standpoint. So let's get into now some of the meat and potatoes of the American Heart Association's guidelines for obstetric cardiac arrest and CPR in 2022. And spoiler alert, big spoiler alert, is that guess what? It's not really very different than most other cardiac arrests. And I really want to hammer this home, and I love the fact that the AHA made this pretty clear. Although there's very sparse evidence, I mean, most of the stuff was like level C evidence, so not very strong, based upon like essentially expert consensus. No RCTs or really strong data. Again, thank goodness, because it's not that common. That they're really hammering home, do the good stuff that we know works really well and don't make a lot of changes. Don't overthink it. With those couple of exceptions that Dr. Garchar talked about, we're doing things essentially the same. And I'll touch on some of those things now. So number one, chest compressions. Usual position as you would for any other adult. We used to say go a little bit higher in gravid females. As it turns out, there was really no data to support that, and we're still saying in the AHA supports center of the chest or the lower half of the sternum, just like you would for any other adult. The rate is essentially the same, greater than 100, allowing recoil of the chest, minimize interruption. They specifically do make the statement that there's not enough data to support recommending mechanical CPR devices. So any one of the devices made by the various companies out there, there will be some, quite frankly, some logistical limitations sometimes based upon the size of the patient or the fact they have a gravid uterus, and sometimes that it is the opposite of what we tend to see in other patient populations where some of these devices, and we've specifically had experience with the Lucas, tend to slide down the sternum toward the abdomen and the xiphoid. In these cases, it can tend to migrate up toward the manubrium or toward the head under those circumstances. And although there's not enough data to really recommend that we use them routinely, I don't think there's any data that suggests that it's dangerous. So if you are in the setting of a very small rural setting facility where you need the hands to potentially do something like prepare for an emergent resuscitative hysterotomy, I would say it is reasonable to use some of these mechanical devices while other hands are doing other important things, getting vascular access or preparing to potentially deliver the fetus. And again, one of the main things, the only differences is making sure someone is immediately providing left manipulation and displacement of the uterus manually. Defibrillation, again, as usual. Generally speaking, apex lateral is fine, totally appropriate, and logistically a little bit easier to avoid pauses in chest compressions while trying to roll over to get to the patient's back. The AHA does specifically state that 200 joules is totally reasonable, and an AED is fine as well. If that's all you have immediately accessible, or for some reason your transport monitor is not functioning or the outside hospital's monitor is not functioning, using an AED is totally appropriate. We talked about airway and breathing, and the AHA does actually suggest that some anesthesia review articles do recommend intubation a little bit earlier. There's really no strong evidence for endotracheal intubation versus supraglottic airway placement, but it's reasonable under in this unique population to, once things get going, to actually intubate the patient, not only for the reasons of specifically the airway and soft tissue swelling, but you may need slightly higher pressures to appropriately ventilate patients in the setting of having a very large gravid uterus that's putting pressure up on their diaphragm, and so I think it's reasonable to consider intubation perhaps a little bit earlier. Again, big caveat there with the lack of data, but I think it's certainly appropriate. Using smaller tubes, that's also part of the recommendations. Weak evidence to support it, but based on the airway swelling, perhaps going down a size for what you'd normally do, about a 6 to a 7. And some of the other rules generally apply. You're trying to get the most experienced laryngoscopist if you're doing it. Minimize attempts and don't ever sacrifice the other really good important things like good chest compressions or prolonging interruptions in chest compressions or delaying defibrillation to provide endotracheal intubation. From a medication standpoint, they're recommending the use of the same medications at the same dosages in adults. They do make the comment that physiological changes may exist and that could alter the effects of the medications, but there's really no scientific evidence or data to justify these changes, and it is unlikely that we will have really strong randomized control trials in the future to really suss that out. So basically, we are doing the same medications. We're not worried about the tetragonicity of these medications. We're not worried about anything else. In the setting of cardiac arrest, do the usual medications at the usual intervals at the usual doses. Fetal monitoring, this one's simple. Don't worry about it. Just like what Dr. Garchar said earlier, it can essentially come off and you can throw the leads in the trash for now. It really doesn't make a difference. Now, one of the really important things that I do want to get to, and I'd like Dr. Garchar to go over, is we talked about that time frame, that important time frame of within about 4 to 5 minutes of potentially delivering the fetus, mainly to help resuscitate mom and to relieve that aortal caval compression that this big gravid uterus is causing. But I will I will defer to Dr. Garchar at this point to talk about what is resuscitative hysterotomy, when would you consider it, Dr. Garchar, and how are you going to do it so our audience kind of gets an idea of what to expect if this is going to go down.
Yeah, so we used to call it a perimortem cesarean, but we really wanted to emphasize exactly what you said. The first and foremost, this is for mom, like that we are improving her resuscitation for sure. Although if the baby is viable, then you would also be helping out baby and minimizing their risk of neurological damage to the fetus. So it's recommended for anyone where you can palpate the fundus at the level of the umbilicus or higher, and that should be at a 20-week gestation. So viability, I would say, especially arguably out in the field, should be about 24 plus weeks. We do offer resuscitation in the hospital with the best of hopes at 22 and 0, but I would say that especially in that setting that I wouldn't expect survival under 24 weeks. And ideally, this should be completed rapidly. So started within 4 minutes and the baby out within the first 5 or so. A good OBGYN can get a baby out in 45 seconds from skin to baby, no problem. And so that is a reasonable time frame. And there is evidence that even within the first 15 to 20 minutes, like if there's an unknown downtime, those kind of things, this can be a helpful thing to consider immediately. So this especially applies to our opiate use disorder patients that will have patients, roll into the trauma bay. And if they have not yet had ROS, we'll consider delivery at that point as well. And we would want to, proceed directly to resuscitative hysterotomy in that setting. So if you come, they've been down, we don't know how long it's been, it's time to do it now. But otherwise, we're trying to wait to see if they have ROS without delivery, especially in the case of a pre-viable, peri-viable fetus, to try to get more time if that's going to be able. Obviously, death 100% crosses the placenta. So if mom's dead, baby's not going to do well. But if we're able to resuscitate mom, that's going to be better. And I would actually perform the procedure myself with, again, a fan and steel skin incision. And that's because that's what I'm most comfortable with. That's what I can get down to a baby in 45 seconds. But if you're having a general surgeon, or especially what's taught in general to emergency medicine providers, is to do a midline vertical incision. And either one, whatever you're most comfortable with. And if you're doing one from the umbilicus inferiorly to the pubic symphysis in a midline, you have the uterus for protection. It's going to keep you from cutting through the intestines, although the bladder is still there. But overall, you're going to be doing okay. And again, if mom's dead, it doesn't really matter. So it's whatever incision you're more comfortable with. So I would do a 11 centimeter fan and steel incision. So I would put my finger at the pubic symphysis and find 2 finger breadths above that, and then do an 11 centimeter incision and get down to the level of the uterus. Well, usually first you'll hit the rectus, pull that open, and there is a general opening of that space. So you have a natural opening with pregnancy. So it should be pretty obvious, even at 20 weeks, where the midline is with that. Opening that up, opening the peritoneum, and then you'll see the uterus sitting right there. And so hysterotomy in the uterus for this setting, I would say however you can get that baby out, especially if you're looking at a 20-week fetus all the way up to about 30 or so. Doing a incision like we normally do, which is a lower uterine segment transverse incision, might be really difficult, and it might be really hard to deliver that baby that way. So doing any sort of incision to open that uterus and get it out. When I do a classical, I almost fillet the uterus in half and open it up. And so if you have to do that, you have to do that. So then you would do like a midline vertical, essentially uterine incision as well. If it's a well-developed lower uterine segment or you're an OBGYN, obviously doing a transverse lower uterine segment incision is great as well. At that point, you remove the baby, and it's also important to get your hand in there and remove the placenta as well, because that is really emptying the contents and getting the uterus totally evacuated down to its baseline size. And that's what's helpful in resuscitation.
Awesome. That was a fantastic review of the procedure, Dr. Garchar. Thank you so much. And I think it's really important for our crews to understand, not necessarily because they're going to be doing the procedure themselves, but because if you might be the set of hands that's assisting, so kind of having a mental model of what to expect and what's going to happen and why it's important, I think is very helpful for crews, because this is a very unique aspect of this particular cardiac arrest. And it seems really, really bad, really, really, really morbid, and it really, really is when you're doing a resuscitative hysterotomy. But in general, in several reviews, that timely resuscitative hysterotomy can result in good outcomes, especially for mom, but also for baby. So in a couple of reviews, and one in particular, they demonstrated in again, very small group of patients, but you're looking at a very good, actually neurologically intact outcome. So in this particular case, when the baby is delivered promptly and appropriately, neurological intact survival to hospital discharge about 78% in mom and 52% of babies. So that's actually really good. That is some of the best outcomes we could consider in cardiac arrest. So knowing when it's time to expect that, potentially prompting or asking the sending physician, or being prepared to help the sending physician with this would be really, really important. So let's say now that you actually have ROSC, fantastic. The post-cardiac arrest care for mom is essentially going to be the same, again, as any other adult. You'll notice like a similar theme throughout this podcast, right? It's going to be the same for any other adult. So that includes maintaining normoxia, so a PaO2 around 60 to 90, or in some institutions 60 to 100, making sure their SATs are not 100%, keeping them somewhere in the mid-90s is totally appropriate. A normal PaCO2, although in general, obstetric patients will tend to be slightly alkalonic, especially toward the second and third trimester. In the setting of post-cardiac arrest, the best data we have would suggest that keeping them in a normal CO2 range of about PaCO2 about 35 to 45 is appropriate, a MAP above 65, and it's also okay to do targeted temperature management in this patient population. All the other good supportive care that we do in critical care transport, including monitoring the EKG, making sure that we have pads on the patient in case they arrest again. If you can get some point of care labs, making sure that we're replacing them. They wouldn't wait at the outside hospital for those necessarily, but if you have them available, potentially replacing some electrolytes that caused an arrhythmia or something would be very, very reasonable. Or treating something like hypermagnesemia would also be a potentially good thing. So keeping an eye on those things. And lastly, the new hotness in cardiac arrest care is eCPR or ECMO. I would say it's fair on behalf of the AHA to not really comment it or talk a lot about it, because there really is not a lot of good data. There are case reports and case series, but the very distinct complications that we have to worry about in this population, like anticoagulation, and actually being able to provide the flow that mom and the fetus need in this particular patient population. But in general, it would be reasonable. And the outcomes in these small case series would suggest that it's about the same outcomes, if not better, than the average adult population that's selected appropriately for eCPR. So the bottom line is, if you are at a center that does ECMO, or you're within striking distance of a program that does ECMO or pre-hospital eCPR, we shouldn't just take that off the plate, especially in the setting of postpartum. So cardiac arrest days or potentially weeks after delivery, I would treat this like our other cardiac arrest patients and go down my checklist, think about reversible causes, and ask myself, I wonder, is this patient actually a candidate for ECMO? So some of the other recommendations and things I would talk about is drills and training. This comes up time and time again because this is a low frequency, high risk situation. Talking about checklists specifically to think about those reversible things in cardiac arrest for the obstetric patient that we generally don't see in the rest of the population, and having SOPs or clinical practice guidelines that are agreed to across your institution, especially if you're a hospital-based program, making sure that the transport team, the ED, the ICU, neonatology, OBGYN, MFM, everybody is on the same page, and there's this shared protocol and mental model. That's something that we at UNM have definitely been working on. And lastly, if there can be one more thing that we do for this population, it is to research this, because a lot of this evidence, again, is level C, which is limited. It's a consensus opinion and expert opinion, which is fine if that's all we've got, but looking at some of this more carefully and seeing how we can help this population out, because again, we are essentially making a few changes. We are doing all the other good cardiac arrest stuff that we do, and if we do it quickly and if we do it really well and we're aggressive, outcomes for obstetric patients that experience cardiac arrest are actually quite good. So with that, I'll ask Dr. Garchar, anything else to share, any other tips, any other stuff from your experience in maternal cardiac arrest?
Yeah, I think we stopped at the baby. So a few other considerations in the setting of a resuscitative hysterotomy once the baby's out. So you've done a giant incision right into the abdomen and into a very vascular structure that's getting up to 750 cc's a minute of blood when you've got a pumping, working heart. So the surgery itself is generally considered completely bloodless because, well, you have cardiac arrest or a very low pressure setting. But if you're getting ROSC, you're going to notice that bleeding starting pretty rapidly and immediately. So if I were doing it, I'd probably close the uterus as fast as I can in order to just be able to have that as a less likely source of bleeding, and then subsequently at least get up to the level of the fascia closed and probably leave the skin alone unless it's heavily bleeding at that point. So definitely remembering that although the surgery itself was probably quick and pretty bloodless, that you can have a huge source of hemorrhage, and also a consideration when you're thinking about the possibility of ECMO in these patients as well, certainly.
And for if we were encouraging our crews to help out sending providers with this part of the procedure, would you be packing the uterus as well, or what would you be doing aside from just whip stitching it shut, or how would you be closing the uterus?
Yeah, I would want to have emptied the contents well. So we love to wipe the inside of the uterus with a couple of laps after we remove the placenta. That's actually not been shown in any study to be helpful or reduce the risk of retained products. So I would say as long as you got the whole placenta out, you are good to just close. You don't need to pack.
Gotcha. Okay, that's super helpful. And then for, again, our crews that are maybe assisting or helping outside providers with this piece of it, is there any specific technique that you would use to close the uterus? Again, would it just be like the particular suture technique that the average emergency physician might be familiar with? What would you recommend as someone who does not suture a whole lot of uteruses?
Yeah, a running locked suture would be the main thing. You want to be able to get that hemostasis because there are huge veins and vessels in that uterus as well.
Awesome. Okay. Well, I'm not sure how I missed going over the open uterus, but thank you so much, Dr. Garchar, for catching that piece of it, because that would be also a very important part of post-resuscitative care for this patients. But overall, kind of like I had said, and I'll reiterate it again and again and again, because I think it's super important, is that early aggressive intervention with these patients is super important. Aside from those handful of things that we talked about, getting specialized help, the manipulation of the uterus, and some potential changes to airway management, you're doing all the other stuff that you guys are awesome at, very well trained to do, and have done a lot in the past. And if you do it well, we're really going to be able to help out this population. So thanks again to Dr. Garchar for being here. Much appreciated.
Yeah, thank you for having me again. I appreciate it. Hope this helps.
And we will be back with future installments of the OB Critical Care in Transport series. Until then, thank you guys very much and fly safe.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.